Okay, we are now starting the second chapter, which is chapter 8, which is about analgesia, which is why I kind of like to combine chapter 7 and chapter 8 because local anesthetics are a large part of achieving analgesia. But we do have specific agents that we do use with our pre-meds, intra-op, post-operatively, and to go home that treat analgesia. So there is a part in the lecture that I'm going to talk about where are we achieving analgesia or what stages do we need to provide analgesia. Well, you definitely, in our pre-meds, it's preemptively, we're pre-treating. You can give pain meds during the surgery, like in the middle of the surgery. Sometimes I have a hard time keeping the patient anesthetized, and it means I keep having to turn up my gas, which means they're typically feeling something. And that's kind of a clue that maybe they need some more analgesia. In the post-operative period, and usually what I mean is that first 24 hours after anesthesia, they're going to still need pain control. And then usually when they're sent home with the owner, we do some level of pain management to send home. Now, if it's something like a spay or a neuter, that might be 2 days, 3 days of pain meds. If we do something like stifle surgery, hip surgery, we may send home a week or two of analgesia. And sometimes I'm not even talking about surgery. It might be arthritis. But because this is an anesthesia class, I'm focusing mostly on treating preoperative, intraoperative, postoperative, and home care pain relief. So basically, pain assessment is part of our anesthetic plan, and it is our job to treat pain. Some people refer to it as the fourth vital sign. So normally when an animal comes into VCA, ER, comes in for surgery, what is their pain level when they come in? Now, if they come in for a spay, we expect their pain level to be 0. We haven't done anything yet. But if they come in like they were hit by a car or they ruptured their cruciate ligament, they are probably in some level of pain when they come to us. Now, the nice thing is when you go to the doctor's office, sometimes they have a picture of those smiley faces, 0 to 10, and they say, rate your pain, 10 being that very grimacy face and 0 being smiley. So we don't have that. We have other ways that I'm going to talk about. We assess pain in our patients. We got to do different. So basically, pain is considered an adverse sensory and emotional experience because if we are in pain, there's usually an emotional response associated with pain. And when an animal feels pain, they're typically going to become protective. You know, if you start to touch a dog and it has a sore leg, they may growl, they may snap. They are trying to protect the area that hurts. So, and what can happen is it can if we don't treat pain, then you have an animal that becomes avoidance, which is basically like they're not going to let you touch them in that area. Sometimes they don't want to be touched at all because they are just so protective and the pain is increasing that they get to this point where they avoid interaction, they avoid touch. Now, a key difference to talk about is, I focus on dogs and cats, but how does a dog react when they're in pain and a cat? Well, a dog tends to be more clingy to the owner. They are in your face and they're whiny, they're leaning on you. They're very, what I would say, outwardly, they show their pain more outwardly. Cats tend to hide. So if like I only have one cat now, but when I had both my cats, they are very interactive. They are in your face. Like when you come home, I would expect to see 2 cats all the time. If I have a cat that all of a sudden isn't in the living room, isn't coming around when I'm in the bathroom, I'm like, that's kind of strange. So sometimes we have to pull out of cat owners what is normal for your cat? For me, my cats are interactive. If they're hiding, that's abnormal. Now, sometimes you have skittish cats that hide when new people come, but you have to find out, what does the cat do with the owner? But they tend to hide, they tend to withdraw. And so there's two very differences of painful appearance. It's going to be a little different. Now, physiology, what is happening in the body? So this isn't like a clinical sign. I can't see physiology. This is what happens. So nociception, which you had to define on your homework, is detection by the nervous system for the potential or actual tissue injury. So the nervous system is responsible for nociception. And what it is designing, the nervous system is protective. So ideally, the reason you react to something is the nervous system wants to protect you. So it protects from painful or noxious stimulus. Noxious is something that will cause injury or pain. So let me talk about physiologic pain. This is more adaptive. This is anticipating. So there may not be an injury. The way I think of this is, have you ever had your hand near a door and you were afraid you're about to squish your hand and you jerk it away? Did you hurt your hand? No. But because maybe you have hurt it before, you're anticipating that if I put it near the door, it's going to hurt. So that's the physiology of your brain and the nervous system potentially protecting you from an injury. So physiologic pain does not have to be an injury. More commonly, and what I want to focus on, is pathologic pain. Pathologic pain actually follows an injury. Now, there are two forms of pathologic pain: acute, which means it just happened, or it's chronic. So acute would be like a spay. When we spay an animal, they didn't come in pain, and we just caused the injury because we did surgery. Chronic might be arthritis. Arthritis builds over time, and arthritis doesn't typically go away. So it's a chronic conditions have been around for an extended period of time. That's the difference between acute and chronic. And I want you to be able to tell me examples of acute injury or acute pain and chronic pain. So let's further classify pathologic pain. How we classify, and path means disease, can be injury, could be a natural disease. What is the mechanism? Is it inflammatory pain? Neuropathic pain happens after nerve injury. Cancer causes pain. Sometimes pain is classified as idiopathic, which means we do not know. There are times that animals show pain. People do this, and we cannot find an actual injury. There is something called referred pain, where sometimes after an amputation, that's phantom pain. The leg is gone. They feel like something is still there. Origin, visceral or somatic. Now, visceral is always pertaining to organs, so that would be deep. Somatic is the general body, so it could be superficial. And then how severe? Mild, moderate. And again, that's where it's difficult, because the animal cannot tell me I'm feeling a 10 out of 10. We have to kind of look at the animal, look at the clinical signs, decide how they are feeling. You need to know the pathway for pain. So the first is transduction. So they take a stimulus, a pain stimulus, they turn it to an electrical signal. If you remember, that's the action potential. So like I've used this analogy before, I touch a hot stove. When the heat is sensed, they take that stimulus, turn it to a signal. Transmission is actually the sensory nerves taking the signal to the spinal cord via an action potential, depolarization. Once in the spinal cord, it's going to be modulated. It can either amplify the signal or suppress the signal. And then once they either amplify or suppress it, you have perception. They are actually sensed in the brain, and it processes this and it recognizes it. So my touch is the hot hand is transduction. Transmission hits the spinal cord. The spinal cord can either speed that up, slow it down. And then when it gets to the brain is then going to decide, what do I do about it? If you've ever sometimes went up to a stove and you're like, okay, it's not hot. You don't always touch something and jerk your hand back. If it's hot, spinal cord's going to amplify that and cause a response. If it doesn't need an immediate response, it's going to maybe slow that down, modulate it. And so the brain isn't going to cause that reaction. Now, this is important, along the pathway, there are different receptors responsible for sensing pain and dealing with pain. When we use different drugs, we can treat an animal via different receptors. Pain medications, they're wide. So each of the drugs I'm going to talk about hit different receptors. They can target it, they can block a receptor, but what I mean by multimodal therapy is targeting 2 or more receptors at the same time. For example, when we give morphine, I target opioid receptors. When I give a non-steroidal anti-inflammatory like Rimadyl, I'm reaching different receptors. I'm using 2 different pain medications to reach 2 different receptors. I'm going to be able to achieve a much greater analgesia level than if I just choose one drug. And that's called multimodal. Now, the reason to treat pain is what happens if I don't treat it. Catabolism is when the body breaks down its own stores. So they can get in this catabolism wasting. Now, after a spay, if they hurt, are they going to waste away? Probably not. But when you get into chronic, like arthritis and cancer, the pain is going to accelerate catabolism and wasting away. Immunosuppression. So the immune system is being taxed when an animal's in pain. And you want your so it's going to make that animal more susceptible to infections because the immune system is being compromised. Inflammation, if a wound is inflamed and it continues to be inflamed, it's not going to heal as fast. If we treat the inflammation, the wound is going to heal much faster. The anesthetic risk, and the big thing here is increased anesthetic doses. Like, I'll give you an example. I can anesthetize a dog for a spay with just gas anesthesia, okay? Now, that is going to involve that dog being wrestled, having a high dose of anesthetic, and I'm going to use that for a lot more. I'm going to have to use a lot more drug. And that puts the patient at risk. If I can turn down my anesthetic level by giving a pre-med of morphine, then I use less anesthesia, which is safer for my patient. And we obviously don't want the patient suffering. What happens when an animal initially feels pain? First of all, hyperalgesia is pain. Hyper is a heightened state of pain. If an animal hurts, all over they're going to be a little bit sensitive. So if a dog has an injury to a leg and it is painful, if you touch anywhere around that leg, not the wound, but anywhere, they're going to be like hyperreactive because the nerves are firing. And what a non-noxious stimulus means is, like, if I touch a dog just to pet them, that's non-noxious. It's a stimulus, but it's not a painful stimulus. But a dog might react like it hurts because an area nearby is painful. That's primary hyperalgesia. If you continue to not treat pain, what happens is when those nerves fire, the central nervous system gets overstimulated. Then what happens, the animal becomes overall hypersensitive. So this might be a dog that has an injured leg. You go to pet the dog and the dog is reacting anywhere you touch it because they are sensitive all over. And this is what happens when the central nervous system is constantly being bombarded with a painful stimulus. This is what we call wind up. So when I asked, I think it was a question on homework, what is wind up? Wind up is a consequence if we do not treat pain. I will tell you that if I give a dog a pre-med, intraoperative morphine, I'm going to be able to use lower doses. If I let an animal get extremely painful and then I go to treat it, I'm going to have to use a much higher dose because I have to overcome the central nervous system being all fired up. So I have to use a much higher dose because all the neurons are hyperexcitable. So that is what primary versus secondary means. Now, what's happening physiologically inside the body? Now, sometimes I ask on a test, how does an animal show me they're painful? And sometimes students put elevated cortisol, ACTH, vasoconstriction. Can I see any of that with the naked eye? No. Physiology is happening in the body. So what happens is the neuroendocrine system puts them in this catabolic state. They release ACTH, which is adrenocorticotropic hormone. Increased ACTH causes the adrenal gland to release cortisol, norepinephrine, epinephrine. Those are your fight and flight hormones. So you're putting an animal in a state of fight and flight. It's also going to consume, or it's going to decrease insulin, which puts me in a hyperglycemic state. I will tell you, sometimes we draw blood on cats that were super stressed and we see an elevated glucose. And a lot of times the doctors, people are like, oh my God, the cat's diabetic. The doctor usually says, was the cat stressed out? Well, most cats are stressed when you draw blood, but some worse than others. And it's truly that because the stress decreased insulin, glucose went up. When you have all this sympathetic nervous system being released, what do we get? That causes vasoconstriction. The heart is beating faster, which increases myocardial work, which is the heart muscle. The harder that muscle works, you have to increase oxygen consumption. When you put all three of these together, this can set up for arrhythmias. Not every patient, but if a patient has an abnormal heartbeat, it can be that they're in this persistent, painful state. So, got to get it treated. Now, how do we know they're painful? If an animal seems stressful, if they seem in this fight or flight response. Now, one thing that anthropomorphists, and I know you guys talked about this in behavior in Tech 1, is we don't want to project our human emotions on the animal. But I will say, what I have done is like, if I was having this procedure, I would be painful. I cannot assume every animal would respond like I would, but we just have to look at them objectively. So the big nuts and bolts of what I've been preaching is the idea of preemptive analgesia. And that definition that you need to know is administration of pain medication before the pain occurs. Like I had used the analogy, I said if I knew I was getting a headache at 4 o'clock, I would take Advil at 3:30. Do you think my headache would be as severe? Maybe I wouldn't even get a headache at all. If I know we are going to spay a dog, why am I going to wait for that dog to show me pain? I know I'm going to cause pain. So let's pre-treat the pain. And I tell you, if you do preemptive analgesia, you achieve a greater level of control and you use much lower doses. So again, reduces the requirements and the duration of anesthesia, administration of pain meds. It prevents wind-up. So if we preempt them, we hopefully don't get into that wind-up state because you're going to use a lot of drug. The best time to do this is at least sometime before surgery. If it's IV, you might be doing it 10 minutes before surgery. If it's IM, it might be 30 minutes. It's just you're giving it before the surgery starts. Now, an animal comes in with an injury, we cannot do preemptive analgesia because the injury occurred. But this is really when I'm talking about doing surgery on a healthy animal that has no pain. Preemptive is going to stop it, hopefully. Now, animals present challenges when we assess pain. In my day, we used to have doctors that said, oh, they're not painful. Or some doctors thought if they felt pain, they wouldn't use the leg after surgery. They thought it would be protective. That's way old thinking. But some animals, depending on species and breed and temperament, are different. Young patients, puppies and kitties, tend to be wimpy when it comes to pain. I remember we had this big Newfoundland puppy. It was only 4 or 5 months old, and it was like 60, 70 pounds. Ate some grapes. So we had to put a catheter in, give it apomorphine, put it on fluids. There was probably 3 or 4 of us laying on this puppy, trying to put in a catheter, and it's screaming bloody murder. All we were doing was putting in an IV. Nothing very painful, but this is a puppy, didn't want to be restrained, didn't want to have a catheter. So the younger patients tend to not be tolerant. The little umfufi dogs, like the Malteses and poodles, tend to be less tolerant. Large breed dogs tend to be more stoic. Aussies are a breed that are particularly stoic. We had an Australian Shepherd that half of its mouth was a tumor. And I knew that hurt. But that dog barely showed any signs of pain. I have to assume it's painful. Is the dog screaming and crying or whining? But it's a very stoic breed. So you get to know that certain breeds are more stoic. And just because they're being calm, you don't want to say they're not painful. We have to assume that if we're doing surgery on a Maltese and we're doing the same surgery on a German Shepherd, they're both going to feel pain. The Maltese may react differently than the German Shepherd. That's what I'm trying to get at. Cattle are more stoic. Cats tend to hide instead of being whiny. What's interesting when you deal with pigs and cows that are typically in a herd, if they sense that an animal is painful, you'll kind of see the herd shift away from that animal. Because in the wild, if an animal is injured or painful, they're most likely going to be prey, and the rest of the herd wants to get away from them. So even though maybe the herd is well protected, that's ingrained in their behavior. It's like, we have to get away from them. So you may be able to identify a sick cow based on it's the one by itself because all these guys are over here. So there is a lot of differences in how animals respond to the pain and the nature of the pain. How long has it been? Also, there's sometimes animals that don't act very painful, and then a person comes around, and all of a sudden we're very dramatic. So it's kind of like there's a difference in a dog that's crying out continuously or a dog that's crying out when people are around. Sometimes there's a level of attention, but to be safe, you always have to assume the animal hurts because we want to make them comfortable. Now, this is an important slide because I feel like you guys are further in the program. You need to get into this advanced level of analysis, advanced level of thinking. How do I know an animal is in pain? There's two ways to look at this. I was an ICU tech, ER tech, and I would be in charge of the animals overnight, the surgery patients. And so for my 12-hour shift, I would have to walk around and check them and make sure they weren't feeling pain. How does an owner know that their animal is painful? Well, one thing is changes in their gait or activity. If you have a dog that could run up the stairs in a millisecond, and now it takes like a good minute or two for them to get upstairs, maybe there's some hip dysplasia, maybe there's some arthritis. They don't want to go on their walks. Now, again, sometimes that's cardiovascular, but remember, when I talked about dogs that are exercise intolerant, arthritis was on that list. I mean, I have anemia, cardiovascular disease, respiratory disease, but if an animal hurts, they don't want to go on a long walk. They don't want to go for a mile run. One thing that we saw a lot in our abdominal cases, like an animal that has an abdominal tumor, and an abdominal tumor doesn't usually grow outward. It could be growing internally, and you don't see it because the dog is big. But that dog tries to lay down, gets up, tries to get down, gets up, shifting to one side. Like I think many of you could probably say your animals at home sleep a certain way the majority of the time. If you take a dog that not normally sleeps on its left side curled up and now it's on its back. You see what I'm trying to say? They're constantly shifting, not sleeping like they used to. Okay. Now, I want to talk about something at the bottom here that I did not mention when I talked about recovery. There is something called emergence delirium. Sometimes when animals wake up from anesthesia, remember, they're coming back to consciousness. Sometimes when they wake up, they are delirious. They're crying, they're screaming, they're paddling. I've had dogs that I've had to like throw myself on top of because they're trying to thrash. And a lot of people are like, oh my God, look how painful he is. If it's emergence delirium, I usually can hold the dog for about 5 minutes, pet him, talk to him, and they calm down. If it's truly pain, I can do all the talking and the comforting and the laying with them that I want. Those animals are going to continue to cry and scream or flail past those 5 minutes, maybe up to 20, 30 minutes. So emergence delirium is not pain. Emergence delirium is them kind of, remember when I said there's that excitement phase? So you go through excitement. Sometimes when you come back out of anesthesia, they hang out in excitement. That's emergence delirium. And it should go away after, say, 5 minutes. Okay, continuing on with physical evidence of pain, there is the primary thing we think about as vocalization, and animals tend to probably do this the most. There can be whining. Some animals are going to growl. Now, growl is a warning, trying to say, stay away from me, I hurt. Groaning, snarling, can be biting, and cats obviously hissing. Potentially purring. Now, we think of purring as a positive. But again, one thing that I have to stress is that an animal, sometimes I have animals emerging from anesthesia crying and whining and howling. And this usually happens the minute you pull the tube, they can vocalize. Remember, an animal cannot vocalize when they're intubated. So sometimes right after I pull the tube, they're, out, and they have this like crying and crying. Again, if it's just anesthesia excitement phase, it'll go away maybe in about 5 minutes because they're going to come out of that excitement. If it continues to persist, this is pain. But one thing I also want to stress about recovery is that an animal is very unpredictable in this scenario. There is animals that will snap and bite when they are waking up. If an animal bites you and they're not completely awake from anesthesia, they can bite and not let go. I had a friend that I worked with, he got bit right after extubation and the dog clamped down. I had to grab propofol and knock the dog back out because we couldn't get the jaws open. He snapped and grabbed. That dog was not conscious when he did that. That was kind of an unconscious response. I've had dogs flail their head, and you got to watch, a lot of people get hit under the jaw because a dog, flails their head. So you always want to make sure you have control of the patient. And a lot of times I can sense that they're going to wake up bad because you feel their body and they're tensing up, they're throwing their head. So always make sure you're very cautious when they're waking up so that they don't injure you, don't injure themselves. And again, I've only said this now 3 times. Emergence delirium goes away. It is not a pain response in about 5 minutes. If it's truly pain, it's going to go on for 5, 10, 15, 20, 25 minutes. You may have to give another pain injection after recovery to enhance their pain. The other thing is like their facial expressions. Are they grimacy? Are they, squinty? So those are, a lot of times in exotics, the way they hold their eyes, and if their fur is ruffled, is a sign of a pain in like a rat or a mouse. And those are things that, you get to know the species you're working with. So you always want to look at that. How do we assess it? Sometimes it's just, I look at the animal and I jot down some notes. More advanced hospitals, veterinary teaching hospitals, specialty hospitals are starting to use different tools, visual scales, acute pain scales. I will tell you, one of the leaders in veterinary pain management was CSU, which is Colorado State University. They came up with an acute pain scale and a feline pain scale. And this was done through research. And, for example, a pain assessment scale is those faces, 0 through 10 in people. But in animals, we got to come up with something else. So this chart, we use something similar to this at VCA. Interaction. Are they awake? Willingly interact? That would be a 0. Awake, reluctant would be a 2. Appearance. Are they calm or are they agitated? 0 to 2. You basically fill out these categories. And again, 2, 4, 6, 8. If you add up all those, if they were a 2 in every category, they would have a scale of a 10 out of 10, would be an extremely painful animal. If they had all zeros, then they would be 0 out of 10, and that's no pain. So this is a very good chart to describe. It's a numeric type scale. Some clinics use a form and there's questions for the owner. There's visual clues. I do not have a picture in this PowerPoint, but I cannot remember the name of the school. They came up, I think it was in Guelph in Canada, the Guelph Veterinary College. In pain for cats, ear position. If you've ever seen a cat and they're very awake and attentive, their ears are up and forward. They're kind of checking everything out. Sometimes their ears will start to dip and bend. And so they have pictures of different ear positions of cats. And that has become a very descriptive tool. So every cat that came in the hospital got one of these sheets and someone would fill out, how did their ear position change pre-surgery, post-surgery? And in cats, I know that sounds weird, what is the position of your ears? But it is a very good predictor in cats. Now, the other thing is we are going to have to assess the patient. Are we meeting their, therapy? There's different types of pain. Again, surgery is acute. Chronic would be arthritis. Some medications and patients are going to be monitored hourly. Sometimes we're going to have a monthly assessment. If it's an arthritis patient, we're probably not going to be assessing them daily. They may come in for a monthly exam. But if we achieve anesthesia or analgesia, we expect to see the behaviors that we saw when they were painful change. One thing is appetite improves. If an animal hurts, they don't eat a lot of times. Cats, this is huge. And please remember this. A happy cat will groom themselves. Sick cats or painful cats tend to not groom. A lot of times when a very sick cat comes in, they look matted, their fur they just look unkept. And it's because that cat hasn't been grooming like it normally would. Their body position and posture and interaction. A cat well, let me get to this picture. Now, there's always a scared cat, but if a cat hurts, they're normally at the back of the cage. They might cower, but if a cat is very happy, ears up, purring, rubbing on you, this cat is obviously, maybe this was a declaw and the other bandage came off, but this cat is very forward, interactive, and obviously this dog looks super happy. Okay, this dog is laying on its back. Anytime a dog exposes its belly, they feel comfortable. They trust you. But a dog that hurts isn't going to be like, here's my belly, come rub me. So these are good visual assessments. It's like in the hospital, what kind of behavior are they showing you? What is the patient showing? Okay, so we get back to what's called perioperative management. Perioperative management means around the whole operative procedure. It begins with preemptive or pre-meds. Sometimes it's going to be given post-operatively. The other thing is fentanyl patches I'm going to talk about. Most of the time a fentanyl patch is used to go home. Sometimes we have a very painful animal. We will put a patch on the day before surgery. So by the time they come into surgery, that patch kicks in. But again, when I talk about multimodal therapy, we're using one or more drugs from different categories to treat pain. Let me make this clear. If I'm using one or more drugs, I never use 2 opioids. I would never give a dog fentanyl and morphine. If I'm going to use an opioid, I pick one. If I'm going to use an NSAID, I pick one. I'm not going to pick Duramax and Rimadyl. They are the same drug, or they have the same family. You always pick one from a family, but I may use 3 drugs from 3 different families to treat one patient. So make sure you understand that. Because we're going to get all the receptors, and by doing that, I'm going to reduce my overall anesthetic, which is always my goal. Your goal is to always achieve anesthetic sparing. Use as little amount of anesthesia as possible. Now, these were the stages I was talking about. What stages of the whole procedure do we have to give? Pre-anesthetic, animals receive pain meds during surgery, during the actual surgery, immediately in that 24 hours post-op, and sometimes animals at BCA, sometimes we have them 3 days after surgery. They're hospitalized. We have to give them pain meds all of those days. And then obviously when we send them home, most animals go home with some type of pain management. What we send home is going to heavily depend on what kind of pain does the animal have, what is their condition, and then how are we going to give it. This is important, and I promise there'll be some kind of question about this on the test, because I'm not going to send home the same pain meds for a spay that I send home a post-op femur fracture. If a dog breaks a bone, That's a lot different than an animal being spayed. Both are painful, but the pain, the level of pain they're feeling is different. Also, route. Now, this is, I really can't press upon you how important client communication is. I don't want to send home an oral medication with an owner with a cat if they cannot give the cat medication. So I always speak to the owner pre-op and say, we're going to send home medicine for pain. Are there any issues giving fluffy medication? And if the owner says I'm comfortable with it, then I know I can send home whatever. But if they say to me, I can't treat this cat at home, and some owners will tell you that, they'll say, I can't touch this cat at home. Okay, then we're going to have to come up with a different plan. That needs to really be decided before surgery. Okay, I'm going to stop this video here, and then I will start recording the next one because I'm going to start talking about the agents themselves.